Your hands do more work more often, with less rest, than almost any other part of your body. They open jars and type on keyboards and button shirts and hold pens and grip steering wheels and prepare food and embrace the people you love. Thousands of small, precise, repetitive movements every single day, performed by some of the smallest and most intricately constructed joints in the entire human body. And when arthritis develops in the hands, which it does, for 30 to 40% of adults over 65, making hand osteoarthritis one of the most common forms of arthritis in older adults. The impact on daily function and independence is often more immediate and more pervasive than arthritis in larger joints like the hip or knee, precisely because the hands are involved in so many more of the small tasks that make up an ordinary day. Yet hand arthritis is one of the least well understood forms of this disease among the people who have it. Most adults with hand arthritis know that their fingers hurt, that their joints look different than they used to, and that certain tasks have become harder. But the specific anatomy of hand arthritis, the patterns that distinguish it from arthritis elsewhere in the body, the treatments that are specifically validated for hand joints rather than simply borrowed from knee and hip arthritis research, and the practical adaptations that preserve function most effectively. This is information that most people with hand arthritis have never received in an organized, comprehensive way. Today I am going to give you 5 important facts about hand arthritis that every person living with this condition deserves to know. Facts about the specific anatomy involved, the patterns of joint involvement that have diagnostic and prognostic significance, the treatments that the research specifically supports for the hands, and the practical strategies that protect hand function for the years ahead. Before we begin, subscribe to this channel right now if you want evidence-based health guidance specifically designed for adults managing arthritis throughout the body. We create this content every week because every joint and every person managing arthritis in it deserves this level of specific, scientific attention. Hit subscribe. The first important fact about hand arthritis is that it is not one condition, but several distinct patterns, each affecting different joints in the hand with different mechanisms and different prognoses, and understanding which pattern you have is essential to understanding your specific disease course and the treatments most likely to help you. The most common pattern is osteoarthritis affecting the distal interphalangeal joints, the joints closest to the fingertips, and the proximal interphalangeal joints, the middle finger joints. This pattern, sometimes called nodal hand osteoarthritis because of the characteristic bony nodules that develop at these joints, has a strong genetic component and occurs disproportionately in women, particularly following menopause, suggesting a significant hormonal influence on its development. The bony enlargements at the distal interphalangeal joints are called Heberden's nodes, and those at the proximal interphalangeal joints are called Bouchard's nodes, named after the physicians who first systematically described them in the 19th century, and recognized today as classic and highly specific clinical signs of hand osteoarthritis. The second major pattern is osteoarthritis at the base of the thumb, specifically the carpometacarpal joint, where the thumb metacarpal meets the trapezium bone of the wrist. This joint, sometimes called the basal joint of the thumb, experiences exceptionally high mechanical stress because of the thumb's unique role in opposition movements, the pinching, gripping, and grasping actions that distinguish human hand function. Thumb base osteoarthritis is so common and so functionally significant that it is sometimes considered almost a separate clinical entity, with its own specific assessment tools, its own specific bracing and splinting approaches, and in advanced cases, its own specific surgical procedures distinct from those used for finger joint arthritis. The third pattern, less common but clinically important to distinguish, is inflammatory arthritis affecting the hands, most significantly rheumatoid arthritis, which characteristically affects the metacarpophalangeal joints, the knuckle joints at the base of the fingers and the wrist, sparing the distal interphalangeal joints that are so characteristically involved in osteoarthritis. This distinction in joint distribution pattern is one of the most clinically useful diagnostic clues available. Osteoarthritis predominantly affects the joints closest to the fingertips and the thumb base, while rheumatoid arthritis predominantly affects the knuckles and wrist, while typically sparing the fingertip joints. A physician evaluating hand pain uses this distribution pattern, combined with the symmetry of involvement, morning stiffness lasting more than 30 minutes, and specific blood tests including rheumatoid factor and anticyclic citrullinated peptide antibodies, to distinguish between these conditions that require substantially different treatment approaches. The second important fact about hand arthritis is that the bony enlargements many people notice represent a specific and somewhat unique biological process worth understanding, because it explains both why these nodules form and why they are generally less concerning than they might appear. The nodules of hand osteoarthritis form, through osteophyte development, the same bone spur formation process that occurs in knee and hip osteoarthritis, but occurring at small joints close to the skin surface, making the bony changes far more visible and palpable. The osteophytes form as the body's attempt to stabilize a joint that has lost cartilage and developed altered mechanical loading patterns, an adaptive, if imperfect, biological response to joint instability rather than a sign of more severe disease than the underlying cartilage loss itself represents. Research has documented that the presence and size of Heberden's and Bouchard's nodes do not correlate strongly with the degree of functional impairment or pain severity in individual experiences, meaning that the visible bumps that often concern patients aesthetically are not the primary determinant of how much the condition affects daily function. Many adults with prominent nodal changes maintain excellent hand function and experience only mild discomfort, while others with less visible joint changes experience more significant pain and functional limitation. This is genuinely reassuring information for the many adults who first notice hand arthritis through the visible nodule changes and who experience anxiety about what this means for their future hand function. The nodules are a marker of the osteoarthritis process, but they are not by themselves a marker of how severely that process will affect your daily life. Before we continue, here's your pause. Do you have visible nodules on your finger joints, either at the joints closest to your fingertips or the middle finger joints? Drop a comment below right now and tell us when you first noticed them and whether anyone explained to you what they represented. We read every comment, and your experience helps this community understand what information about hand arthritis is most needed. The third important fact about hand arthritis is that the thumb base joint has specific bracing and splinting treatments with substantially stronger evidence behind them than equivalent approaches for finger joint or knee arthritis. A thumb spica splint, a specifically designed brace that immobilizes the carpontocarpal joint while preserving mobility of the wrist and other fingers, has been studied in multiple randomized controlled trials, with research published in the Journal of Hand Therapy finding that consistent splint use produced significant reductions in pain and significant improvements in pinch and grip strength compared to no splinting, with the greatest benefits observed in patients who wore the splint during the specific activities: opening jars, writing, using tools that most provoked their thumb pain, rather than continuously throughout all waking hours. This activity-specific splinting approach reflects an important principle that differs from continuous bracing sometimes recommended for larger joints. Because hand function requires such frequent and varied movement for daily tasks, continuous splinting can produce stiffness and muscle weakness that outweighs the benefit of joint protection during hours when the joint is not under significant mechanical stress. The evidence-based approach is targeted splinting during the highest stress activities, specifically preserving full hand mobility during the remainder of the day. Hand exercises specifically designed for osteoarthritis have their own dedicated evidence base. Research published in the Annals of the Rheumatic Diseases found that a structured hand exercise program combining range of motion exercises, gentle strengthening, and functional task practice produced significant improvements in hand pain, grip strength, and pinch strength in adults with hand osteoarthritis, with benefits sustained at 12-month follow-up in patients who continued the exercises regularly. These hand-specific exercises typically include gentle finger and thumb stretches, isometric strengthening using therapy putty or a softball, and functional practice of the specific grip and pinch patterns daily activities require. The fourth important fact about hand arthritis is that assistive devices and ergonomic modifications have a uniquely large impact on functional outcomes, larger, in practical terms, than for almost any other joint, because the hand's role in fine motor tasks means that relatively small modifications to how a task is performed can produce disproportionately large reductions in joint stress. Jar openers, key turners, and build-up grips on pens and utensils reduce the pinch force required for tasks that would otherwise place significant stress on an arthritic thumb base or finger joints. Research on ergonomic hand tool modification has documented that built-up grip diameters reduce the grip force required to maintain control during use, directly reducing joint loading on osteoarthritic finger and thumb joints. Button hooks, zipper pulls, and Velcro closures reduce the fine pinch and rotation movements, often among the most painful activities for adults with thumb base and finger joint osteoarthritis. Voice-to-text technology and ergonomic keyboard and mouse alternatives address the specific demands of computer and smartphone use that place sustained repetitive stress on finger and wrist joints. For adults whose hand arthritis is significantly provoked by typing or smartphone use, voice dictation software, larger touchscreen targets, and stylus tools represent practical modern adaptations increasingly incorporated into comprehensive treatment recommendations. The fifth important fact about hand arthritis is that the pharmacological and injection treatments most effective for hand arthritis specifically differ in some important ways from those most studied for knee and hip osteoarthritis. Topical NSAIDs, specifically topical diclofenac, have strong evidence specifically for hand osteoarthritis as well, with the American College of Rheumatology guidelines specifically recommending topical NSAIDs as a first-line pharmacological treatment for hand osteoarthritis, just as for knee osteoarthritis. The small surface area and superficial location of hand joints make topical application particularly practical and effective. Corticosteroid injections into the thumb base joint specifically have documented evidence for providing meaningful, if temporary, pain relief, with research suggesting that the response to these injections may also have prognostic value. Patients who respond well may be more likely to benefit from surgical intervention sometimes considered for advanced thumb base arthritis. The nutritional and supplement interventions we have detailed extensively throughout this arthritis series: vitamin D, omega-3 fatty acids, curcumin. The anti-inflammatory dietary pattern apply to hand osteoarthritis through the same systemic anti-inflammatory and chondroprotective mechanisms we have described for other joints, since these interventions work through systemic pathways rather than joint-specific ones. There is no reason to expect that the vitamin D receptor-mediated cartilage protection or the omega-3 resolvin production that benefits knee cartilage would not similarly benefit the cartilage of the small joints of the hand. For severe thumb base osteoarthritis that has not responded adequately to the comprehensive non-surgical approach, surgical options including trapeziectomy, removal of the trapezium bone with or without ligament reconstruction, have decades of clinical experience and generally favorable outcomes. The prevalence and risk factor dimension of hand osteoarthritis deserves additional detail. The genetic component of nodal hand osteoarthritis is among the strongest genetic influences identified for any form of osteoarthritis. Research examining family patterns and twin studies has found heritability estimates for nodal hand osteoarthritis in the range of 50 to 65%. Specific genetic variants affecting cartilage matrix proteins, including variants in the gene encoding type I collagen, have been associated with increased nodal hand osteoarthritis risk in genome-wide association studies. This strong genetic component explains the characteristic family pattern. Many adults recognize a mother or grandmother with similarly enlarged finger joints, sisters who develop the same pattern at similar ages. The hormonal influence on nodal hand osteoarthritis reflected in its disproportionate occurrence in women, particularly accelerating around menopause, has been an area of active research investigating estrogen's role in cartilage maintenance. Estrogen receptors are present in the cartilage and synovial tissue of hand joints, and the decline in estrogen production at menopause is hypothesized to remove a protective influence on cartilage maintenance that may partially explain both the female predominance of this condition and its frequent acceleration during the postmenopausal years. The relationship between hand osteoarthritis and osteoarthritis at other joints in the body is also worth understanding. Adults who develop nodal hand osteoarthritis have a documented increased risk of developing osteoarthritis at the knee and other joints, suggesting that nodal hand osteoarthritis may serve as a marker of a more generalized predisposition to osteoarthritis throughout the body. Research has found that adults with Heberden's nodes have a significantly elevated risk of subsequently developing symptomatic knee osteoarthritis compared to those without nodal hand changes. This connection reinforces the value of the comprehensive whole-body approach to arthritis prevention and management this channel has consistently emphasized. The anti-inflammatory dietary pattern, the appropriate exercise program, the proven vitamin and supplement protocol, and the weight management strategies that protect weight-bearing joints represent the systemic foundation that supports joint health throughout the body, including but not limited to the hands. The complete picture of comprehensive hand arthritis management integrates seamlessly with the comprehensive arthritis management program, detailed throughout this entire channel. The exercise component shifts from quadriceps and hip strengthening to hand-specific range of motion and grip strengthening exercises. The bracing component shifts from knee unloader braces to activity-specific thumb spica splinting. The pharmacological approach remains substantially similar, with topical NSAIDs as first-line treatment. And the nutritional and systemic anti-inflammatory foundation applies without modification, since these interventions work through systemic biological pathways that benefit cartilage throughout the body. For adults managing hand arthritis specifically, the practical Talkie Way is a 5-point action plan. Identify which pattern of hand arthritis you have and discuss the diagnostic distinction with your physician. If uncertain, understand that visible nodules do not predict the severity of your functional limitation. Implement activity-specific thumb splinting and a dedicated hand exercise program. Adopt the specific ergonomic modifications most relevant to your daily tasks and maintain the comprehensive systemic anti-inflammatory and joint protective program detailed throughout this channel. Recognizing its relevance to your broader joint health, given the elevated risk of knee and other joint involvement that accompanies nodal hand osteoarthritis specifically. Your hands have carried you through every handshake, every meal prepared, every child held, every task completed across a lifetime of use. The arthritis that may now affect them deserves the same evidence-based, comprehensive, specifically informed approach that this channel has provided for every other joint in the body, because your hands, and the function and independence they provide, are worth exactly that level of care. The osteoarthritis affecting the wrist itself, distinct from both the thumb base osteoarthritis and the finger joint patterns we have described, deserves brief mention because it represents a less common but clinically important fourth pattern of hand region arthritis that adults experiencing wrist pain alongside finger involvement should understand. Primary wrist osteoarthritis, without an underlying cause such as previous fracture or ligament injury, is relatively uncommon compared to the nodal finger pattern and the thumb base pattern we discussed as the two most prevalent forms of hand osteoarthritis. When wrist osteoarthritis does occur as a primary condition, it most commonly affects the joint between the scaphoid and trapezium bones, often in association with thumb base osteoarthritis given the close anatomical and functional relationship between these structures. Secondary wrist osteoarthritis developing as a consequence of previous wrist fracture, particularly scaphoid fractures that have healed with altered carpal bone alignment, or following ligament injuries that destabilize the normal wrist mechanics, is more common than primary wrist osteoarthritis and follows a different diagnostic and management pathway that depends heavily on the specific prior injury and the resulting altered biomechanics. For adults experiencing wrist pain alongside the finger and thumb symptoms we have described, distinguishing primary wrist osteoarthritis from the more common secondary forms, and distinguishing either from the inflammatory arthritis pattern that characteristically involves the wrist in rheumatoid disease, requires the same physician evaluation and imaging assessment we have emphasized throughout this video, because the management approach differs substantially depending on which of these patterns is present. The systemic and psychological burden of hand arthritis specifically deserves acknowledgement beyond the purely biomechanical and pharmacological information we have provided, because hand function carries a unique psychological significance related to independence, identity, and social connection that arthritis in other joints does not carry to quite the same degree. The hands are how we shake another person's hand in greeting, how we hold a grandchild, how we prepare meals for the people we love, how we create through craft, art or music, and how we perform the thousands of small acts of daily self-care that maintain our sense of independence and dignity. Research examining the psychological impact of hand osteoarthritis specifically has documented that functional limitation in hand tasks is associated with measurable impacts on mood, social participation, and quality of life that are disproportionate to what might be predicted from pain severity alone, reflecting the unique role the hand function plays in identity and independence for most adults. This psychological dimension is not separate from the comprehensive management approach we have described throughout this video. It is a reason that the functional preservation strategies, the splinting, the exercise, the ergonomic adaptation matter as much for psychological well-being as for the purely physical preservation of joint structure and function. For adults who find that hand arthritis is affecting their sense of independence, their ability to participate in valued activities, or their overall mood and outlook, this is a legitimate and important component of the condition to discuss with a physician or occupational therapist professionals who specialize in hand function, and who can provide both the practical adaptive strategies and, where appropriate, the connection to mental health support that addresses the genuine psychological impact the hand function limitation can produce. The occupational therapy referral specifically deserves mention as an underutilized resource for adults with hand arthritis. Occupational therapists specializing in hand conditions provide individualized assessment of the specific tasks most affected by an individual's hand arthritis pattern, custom-fitted splinting that is more precisely tailored than over-the-counter options, hands-on instruction in joint protection techniques during specific daily activities, and ongoing monitoring of hand function over time. For adults with hand arthritis whose symptoms are significantly affecting daily function, a referral to occupational therapy represents one of the most directly actionable and individually tailored interventions available, providing a level of specific, hands-on guidance that this video, however comprehensive, cannot replicate for your individual hand anatomy and your individual pattern of daily activities. This complete picture of hand arthritis, the distinct patterns and their diagnostic significance, the relatively benign implication of visible nodules, the strong evidence for activity-specific splinting and hand-specific exercise, the disproportionate value of ergonomic adaptation, the joint-specific pharmacological evidence, the genetic and hormonal risk factors, the connection to broader joint health, and the psychological dimension that hand function carries represents the comprehensive, specifically informed understanding that adults living with this condition deserve, rather than the generic extrapolation from other joints that so often constitutes the only information available. The night splinting consideration for hand osteoarthritis deserves specific mention as a complementary strategy to the activity-specific daytime splinting we described, because the overnight period presents a different set of considerations than the active daytime hours when targeted splinting during specific high-stress activities is the evidence-based approach. Some adults with hand osteoarthritis, particularly those with significant morning stiffness or pain that is worse upon waking, find benefit from a different splinting strategy overnight, a resting splint that maintains the hand and wrist in a comfortable, neutral position throughout sleep, reducing the joint stress that can occur from unconscious hand positioning during sleep, and potentially reducing the morning stiffness that many adults with hand osteoarthritis experience. This is a distinct application from the activity-specific daytime splinting we described, and the evidence base for night splinting specifically is less robust than for the activity-specific thumb-spica splinting we detailed. But it remains a reasonable strategy worth discussing with an occupational therapist or hand specialist for adults whose primary symptom burden is concentrated in the morning hours. The temperature and weather sensitivity that many adults with hand osteoarthritis report worsened symptoms during cold weather or with exposure to cold water or air conditioning is a commonly reported but incompletely understood phenomenon in osteoarthritis research generally, with hand osteoarthritis being one of the joint locations where this weather sensitivity is most frequently and most strongly reported by patients. The proposed mechanisms include the effect of cold temperature on synovial fluid viscosity, similar to the mechanism we described in our walking video regarding morning joint stiffness, as well as potential effects of barometric pressure changes on joint capsule pressure and nerve sensitivity. While the research on weather and arthritis symptoms has produced inconsistent findings overall, with some studies finding clear associations and others finding none, the consistency with which individual patients report this pattern in their own experience suggests it reflects a genuine, if individually variable, physiological phenomenon rather than simply a perceptual bias. For adults who notice this pattern in their own hand arthritis, practical management includes keeping the hands warm during cold weather exposure through gloves and hand warmers, running hands under warm water before activities that require fine motor precision during cold conditions, and considering the timing of more demanding hand tasks to periods when the hands have had time to warm from the ambient cold temperature, particularly during the colder months when this weather sensitivity is most relevant. The relationship between hand osteoarthritis and grip strength specifically deserves attention because grip strength has emerged as an important biomarker in aging research more broadly, with reduced grip strength associated not only with hand-specific functional limitation, but with broader measures of frailty, fall risk, and even mortality risk in population studies of older adults. This connection means that the hand exercise programs we described, which specifically aim to maintain grip and pinch strength despite the joint changes of hand osteoarthritis, may have benefits that extend beyond hand-specific function to the broader markers of healthy aging that grip strength represents. Research examining grip strength trajectories in adults with hand osteoarthritis who participate in structured hand exercise programs compared to those who do not has found that the exercise group maintains significantly better grip strength over follow-up periods extending several years, providing a specific, measurable target that adults with hand osteoarthritis can track over time as an indicator of both their hand-specific function and their broader physical resilience as they age. A simple hand dynamometer, available at modest cost or often accessible through physical therapy or occupational therapy clinics, allows adults with hand osteoarthritis to track their grip strength over time, providing the same kind of objective outcome tracking that the KOOS and WOMAC scores provide for knee osteoarthritis that we described in previous videos in this series. This comprehensive treatment of hand arthritis covering the distinct anatomical patterns, the relatively benign significance of visible changes, the joint-specific evidence for splinting and exercise, the value of ergonomic adaptation, the specific pharmacological approaches, the genetic and hormonal risk factors, the connection to systemic joint health, the psychological dimension of hand function, and the practical considerations of night splinting, weather sensitivity, and grip strength. Tracking represents the complete, specifically informed picture that this video set out to provide. Your hands are remarkable instruments of daily life and human connection. The arthritis affecting them deserves nothing less than the complete, evidence-based understanding this video has provided, and the comprehensive management approach that follows from that understanding. If this video gave you the specific, comprehensive understanding of hand arthritis that you have been looking for, please support this channel. Hit the like button right now. Subscribe if you have not already. Share this video with someone managing arthritis in their hands who has never received this level of specific guidance. And leave a comment below. Tell us which pattern of hand arthritis you have, which of the 5 facts was most useful to you, and what you are going to discuss at your next physician appointment. We read every comment. Thank you so much for watching. See you in the next one.